Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Jump in right straight away with continuation of our presentation from 2 weeks ago. Dr. Ebrashi, please go ahead and take this.
Thank you. Thank you all for coming back. We are going to continue our journey talking about Edentulism and the transition to Edentulism and heading towards more complex implant rehabilitation of patients. So what are the things that you take into account when you are transitioning a patient towards being edentulous, or as they start to need some kind of removal prosthesis? Well, we've got to look at it in several different dimensions. Firstly, the medical history. That's critical. You know, if you have a patient who's on anticoagulants and so on, they need to be managed appropriately. If they're on Coumadin, you have to have an INR within an appropriate range. If they're on a platelet inhibitor, such as Eliquis or aspirin or Plavix, how many days prior to the procedure are you stopping? Does that set them up for some kind of potential from an embolism if they're a high-risk patient? And that is a critical part of managing these patients. And I'm fortunate that my partner is an MD as well as a DDS, so I leave a lot of that management to him. So there's the preoperative management of the patient in terms of the things that you anticipate, and then there's the unanticipated consequences or complications. And I'll give you an example. We have a patient who was on Coumadin. We did an upper hybrid prosthesis for him. He'd stopped his medication, say on a Monday. We did an INR on the morning of the procedure. The values were appropriate. And then the night of the procedure, so 12 hours after the surgery, he doubled up on his Coumadin because he got confused. And then, of course, cold, was bleeding. Had to bring him back in, remove the prostheses that night, cauterize, close everything up, did not put the prosthesis back in. So some of these complications, you have an idea they're going to happen. Some of them are going to be due to poor patient compliance. Then there's the dental management of the patient. And this case illustrates things fairly well. So here is a patient in a sort of perio collapse case, as I call it. No posterior occlusion, anterior teeth are starting to flare. And how do you transition that patient into a partially dentate state using a removal prosthesis? And how do you manage the patient as the ridge starts to resorb and so on? And how do you educate the patient about the things they expect to see with regard to pronunciation, fit of the prostheses, appearance, and so on? Because we know that with these types of prostheses, we cannot do a wax trim because the patient was already dentate. So if you have a patient who's very demanding, what you do is you take your impressions, you arrange the teeth in wax, and you let them have a look at the wax up on the articulator. But that gives you a little bit of a red flag that you have a patient who perhaps is going to be difficult to manage. So a good preliminary alginate is important. What you're trying to do is capture the peripheral border. Obviously, we don't need a posterior palatal seal with this type of prosthesis because it is a tooth and tissue supported prosthesis. You're going to mount the case typically in MI. We can talk about the discrepancy between CR and CO and freedom and centric and so on. That's a different conversation. Remove the teeth that are going to be extracted, arrange them appropriately, understand there's going to be a flange there, figure out what your path of insertion is going to be, where your raw clasps are. Typically, the raw clasps are on the distal abutment, in this case, upper right molar, upper left molar. Process the case in acrylic. Make sure that when you come in to deliver the case that you're able to adjust the interproximal embrasures and the gingival embrasures to allow this prosthesis to seat well. Deliver the prosthesis, making sure that you don't have excess pressure. And these slides from Dr. Sutton in the UK. You can see aesthetically, it's a very, very well set up case. It's not perfect because the shade or the value of these is a little light compared to the others. And you can see the posterior plane of occlusion. We've had some super eruption and so on, but it's a nice aesthetic start for this patient as he heads down potentially to more extractions and maybe heading towards a complete denture. So when we talk about the Edentulous predicament, what is that? And for those of you who don't recognize this is George Washington. And George Washington had some wooden dentures with ivory teeth on there. And you can see this is a classically edentulous appearance. When we have a look at his lower facial third, here he is as an old man. Here he is as a younger man when he was still dentate. When we have a look at the lower facial third, the middle facial third, and the upper third, they're approximately in proportion, 1/3, 1/3, 1/3. When we have a look here, this is collapsed. He has a little bit of a prognathic mandible. And if we were to look at him in profile, this is going to be undersupported. And so that's the classic edentulous predicament. What do I mean by that? Well, we all have a mental picture of the ideal patient with a good ridge, ideal muscle attachments, good salivary flow, philosophical personality, appreciative patient, and somebody who has a potential to adapt well to a removable prosthesis. Unfortunately, many patients don't have a philosophical outlook. They often have medication-induced dry mouth or xerostomia. Significant resorption of the posterior ridges in the mandible because they've retained anterior teeth, canine to canine. And we have a patient who has high expectations, and sometimes our ability to fabricate a well-made, especially a mandibular complete denture, can be very challenging. And so they're very underwhelmed. And so sometimes you have an unpredictable treatment outcome. We have a maladaptive patient or a patient who doesn't respond very well. They may have unnecessarily high expectations. Obviously, they have no prior complete denture experience. The question becomes, do they have experience with a removable partial denture or an interim partial denture, such as a flipper? They may have significant ridge resorption, dry mouth, and they may have some prolapse or high muscle attachments. For example, the genial tubercles, if there's been extractions a long time ago, this anterior vestibular depth and width becomes narrow. The mentalis muscle, if it's overactive, means you have minimal buccal vestibule. And as you get the ridge resorption, as we know the mandible is resorbing down and forward, effectively the genial tubercles on the lingual, where the genioglossus attaches to the mandible, become pretty superficial. So you end up with a very short vestibule anteriorly. In the buccal vestibule in the posterior mandible, you may have an adequate vestibular depth, but the patient can't tolerate it. And then, of course, we know as we get towards the retromylohyoid area that there's lots of undercut there, but lots of patients cannot adapt to that. And as many of you know, there are thousands of complete dentures made that don't cover basic anatomic landmarks, such as the retromolar fossa. And we can run into problems with those patients because the denture is poorly fabricated. It becomes very difficult for the patient to tolerate. So the question really becomes, did they do poorly because of their expectations, or did we do poorly and they didn't know that the prosthesis was inadequately fabricated, and hence they're adapting poorly? So basic landmarks like the retromolar pad are important to cover, and impression making is very important. And so what's the difference between a possible and probable outcome? And so when we look at the maxillary arch, what is the primary stress-bearing area? It's typically the palate. Obviously, we have the incisive papilla, the mid-palatine raphe, the lateral hard palate, the tuberosity, and the residual ridge. In this patient, you'd expect them to do fairly well with an upper denture. When we look at the things that are important is the degree and the nature of the denture mucosa, what's attached and what is not, the amount of keratinization. Does the patient have a large palatal torus? Does the patient have some buccal undercuts of buccal exostoses? And if they're unilateral, that's okay. But if they're bilateral, that becomes very difficult. What's the ridge height? What's the hard palate form? Is it a patient with a very narrow, deep palatal vault, which can be extremely difficult? What are the tuberosities like? And the muscle attachments, are the freni multiple? Do you have 2 or 3 buccal freni and a low attaching midline frenum? How many notches, have you captured those appropriately? What's the soft palate form like, and how have you recorded that? And we know this area here, the soft palate, has a wide range of functional movements, both in speech and swallowing. So the posterior palatal seal is often a critical area that if you don't record it, if you don't capture it in a state of function, and that may be a matter of taking a thermoplastic material such as compound or wax, having the patient do the Valsalva maneuver and say, ah, and trying to capture that tissue as it's moving. And oftentimes you can challenge the posterior palatal seal by taking your finger, putting it behind maxillary incisors and trying to trip the denture. And if the denture comes down fairly easily, then perhaps you need to add some more material, whether it's extension or depth, but that is an area that's often underlooked. What about saliva flow? Nobody really talks about this thing. How do we measure quality and quantity? Well, it's very subjective. We know that the parotid flow is serous. Submandibular and singular sublingual glands give you a mixed flow, mucinous serous, and the palatine glands are mucinous. Excess serous saliva affects the retention of a complete denture by disrupting the border seal. So if you're having a lot of flow from the parotid, that can affect retention. The more viscous secretion of the palatine glands is what you really want, and that plays a positive role in the retention of an upper complete denture. When we look at mandibular ridges, we want to look at the residual ridge form, the mylohyoid ridge on the lingual, the retromolar pads, the buccal shelf, and as I said, the genial tubercles here, and oftentimes the mentalis muscle. And you know, at what point are you doing a biopsy? You've got bilateral hyperkeratosis. Is this something that you're worried about? And when do you interfere, or when do you intervene and say to the patient, I'm not happy with this. This could be something such as melanoma, or is it an amalgam tattoo? If you see a piece of amalgam residue on your PA and it sort of matches with the equivalent of an amalgam tattoo, then you don't biopsy that. But if it's something that's developed within the last year or two, then you do need to consider pathology. Again, similar things that we look at, attached versus non-attached mucosa, the amount of keratinization, the ridge height and the contour. Does the patient have mandibular tori or buccal exostoses? Because they may need to be removed. The ridge consistency, the frenal attachments, the labial frenum, the buccal frenum, of course, the lingual frenum with the genial tubercle, the floor of the mouth and the mylohyoid muscle, the mentalis muscle here, masseter muscle on the distal buccal. The tongue size and posture is critical. There was a paper written by a fellow called Wright, W-R-I-G-H-T, from the University of Michigan, I believe in the 1950s or 60s, that specifically talks about retruded tongue position and how that affects a denture. And again, subjectively, you don't know how a patient's tongue is going to affect their ability to retain a denture. I will tell you this, if a patient has macroglossia and severe sleep apnea, their ability to tolerate a removable prosthesis is going to be very different than if that patient has a normal sized tongue and they don't have sleep apnea. The retromylohyoid space back here and the undercuts, retromolar pad, that's a critical landmark. and when we think of what we call Neal's lateral throat form classification. That depends on the extent of the anterior movement of the retromylohyoid curtain as the tongue extends anteriorly beyond the vermilion border. What does that mean in English? It means you take your finger and you put it back in that area and you thrust your tongue out. The more resistance that you have to that movement, the more the classification tends to be 1, 2, or 3. So 1 so 3 is excessive pressure. 2 is sort of adequate pressure, and 1 is minimal pressure. And they say, according to this, again, another subjective classification, 75% of patients have a normal lateral throat form, and then 25 have class 2, class 3. But again, very difficult thing to measure because it's subjective. And when we look at a denture, whether it's mandibular or maxillary, there are 3 surfaces: the occlusal surface, and we can talk about occlusal schemes, whether it's lingualized occlusion or bilateral balanced. The polished surface, which is the pink, which allows neuromuscular control, allowing a positive muscle action and movement without impingement. When you look at the denture contours here, this was made by one of my students when I was teaching at OHSU, you can see this really gives you a good mental picture of how these muscles, this is where the master muscle is going to interact, buccinator here, mentalis here, mylohyoid, and then of course the lateral and dorsal surface of the tongue. And then the fitting surface. And the fitting surface is often a surface that we all talk about as being the most critical, but if these 2 surfaces are not in harmony with the fitting surface, in other words, you have a good impression, you've made a good impression, but your CR record and your arrangement of the teeth is poorly done, it means that your occlusal relationship is off. And if the polished surface also has inappropriate contour, you're going to have overextension or underextension, allowing ingress of air, which then affects your fitting surface. And so the impression surface is critical because you get your retention through adhesion and atmospheric pressure. The polished surface, like we said, it's a complex surface, significant impact on a patient's ability to tolerate a denture. And the occlusal surface affects the balance of the prosthesis in function. There's an old prosthodontic expression called enter bolus, exit balance. If we have set this case up as a bilateral balanced occlusion, so that as the patient goes into excursions, they're having contact on the working and the non-working side. As the patient starts to masticate, how's the balance of that prosthesis? And so typically we're looking for retention, which is resistance to displacement away from the ridge. We want stability, which is resistance to horizontal and rotational forces. And of course, we want support, which is resistance to tissue ward movement. What does that mean? That means movement towards the tissues, which will often cause ulceration. You can see this is an excellent outline of the mylohyoid for a mandibular overdenture. The problem with mandibular overdentures, they're often made with a poor contour. So you're really just relying upon the implants to give you retention when the rest of the prosthesis is inadequately extended. Let's now segue into the neutral zone and what that is. The neutral zone is the area where outward forces of the tongue are neutralized by the inward forces of the cheeks and the lips. So when you think of all these muscles that contribute to our sort of perioral function, and what we call the modulus, and how you have orbicularis oris fibers and buccinated fibers basically interlacing and going upside down. That's a critical portion of your lip function. And of course, the master muscle is very important. If you impinge upon the neutral zone, you arrange your teeth in a position that the patient cannot tolerate. In other words, you bring them too far lingually and they have a tongue thrust, that's going to disturb the seal of your denture. So there are dislocating muscles and fixing muscles with regard to a lower complete denture. And the dislocating muscles on the buccal tend to be the masseter, the mentalis, and the incivus labii inferioris. Lingually, it tends to be the medial pterygoid, palatoglossus, styloglossus, and the mylohyoid. So styloglossus, like it says, it comes from the stylo process towards the tongue. Palatal glossus from the soft palate to the tongue. The fixing muscles are few and far between. Buccally, they're the buccinator and the orbicularis oris. And lingually, it's basically the tongue. Junior glossus, and these are all muscles within the mass of the tongue itself, lingual, vertical. So the tongue really is going to give you a lot of that stabilizing on the lingual. And unfortunately, lots of patients show up with what I call a bag o' dentures. I have many patients who show up with 8, 10 dentures, and I tease them. I said, these are for Monday and Wednesday, those are Tuesday, Thursday, and the others are for the weekend, and they sort of laugh. And so there was a prosthodontist from probably 100 years ago who talked about patient classification and psychological classification, and he broke down patients into 4 categories: indifferent, philosophical, exacting, and hysterical. And it's a fairly broad classification, and it's been talked about since, and I believe that Goodacre published something in the Journal of Pros that re-examined it. But it is a classification that I use fairly routinely when I'm trying to figure out what type of person am I dealing with. Do I have an engineer type or a physician or a lawyer who's very precise and exacting? Or do I have somebody who is a poet or an artist who's philosophical and who's willing to go back and forth? Because those 2 personality types I can work with pretty well. I have a problem with the hysterical patient or the narcissistic patient because often their expectations are beyond what I can provide. Unfortunately, they don't come in with a big red flag saying, hey, I am going to be very challenging. The medical history will often show you or give you clues that something is going on. And then the indifferent patient is tough because they're not invested in treatment and they're sort of ambivalent. So the conclusions, and this is a paper that was published in 2010 from the University of Newcastle, my old school. Technically sound prostheses can be made with patients with a well-formed mandibular ridges and accurate CR record. Those are positive indicators for success. A neurotic patient and a poor mandibular ridge are negative indicators for success, basically the opposite of the first statement. And a minority of patients may never adapt to any complete denture. The issue is, how do you predict who those people are? And again, that's a difficult thing, and it takes years to sort of master that. This is the very first complete denture patient I treated in 1995 at the University of Michigan. These are porcelain teeth. You can see she's assumed a more protrusive position. She's a class 3 patient. Obviously, from a ridge standpoint, she was a class 3 patient. And I'd never made a denture with a crossbite before. And I did this with Dr. Charles Kelsey, who's no longer around. But I remember thinking to myself, how's she going to function in crossbite? And if you look carefully, she has 1 bi and 2 molars. There's not enough room for 2 premolars and 2 molars. And obviously, we have gone for a 0-degree rational setup so the patient can go side to side and forward and back. And so when we talk about the maxillomandibular relationship with the patient, the maxillomandibular relationship is the AP relationship. Let me just move this, sorry. The anterior-posterior relationship of the mandibular ridge relative to the maxillary residual ridge when the jaws are in centric relation and are separated by the distance they will be by the prostheses. So obviously, the height of the prostheses affects your vertical dimension, and it's going to affect your CR position. And did you record your patient in CR, or did they protrude, or did they go towards one side or the other? And so what's your degree of dental compensation for a pre-existing skeletal relationship? Here is a patient who's a class 2. Are you going to try to bring the maxillary teeth back? And if so, are they just going to be little almond shells on the outside with just a minimal amount of acrylic for the teeth because you've had to cut away so much? Or are you going to leave the patient in a class 2? And how does that affect their lip support if they've been a class 2 all along and you move everything back lingually significantly? They may feel very under-supported, and they may feel locked in because you've trapped their occlusion, so to speak. And so what are the consequences of ridge resorption, residual ridge resorption in one arch here in the maxilla versus the other? And aesthetically, how does that impact the patient and functionally? So when we look at this patient who was a pilot, here is his upper partial denture, if you can believe that's a partial denture, against his mandibular partially dentate arch. And look at the relationship that he's assumed. He has no prosthesis in the mandible. So in this instance, we took out the lower remaining teeth in the mandible and the super erupted tooth in the maxilla and tried to get him back into a class 1 relationship. So what you're trying to do is you're critically evaluating the arch alignment, the inter-ridge relationship, to give you a treatment plan that allows you to enhance the strength and diminish the weaknesses of the underlying structures. I know this patient is going to tolerate a maxillary complete denture well because he's basically wearing an ill-fitting removable prosthesis. He's never been able to tolerate a mandibular RPD. So in this instance, I've given him something that's fixed. So I'm trying to look at his experience and help me understand how can I get him to a position where he'll accept the treatment plan that I've provided. And how accurate is my mounting? So complete dentures are designed to harmonize with unconditioned swallowing reflexes as the mandible is at or near the CR position when swallowed. And so what are the factors that influence your CR records? There are patient factors, the patient health and cooperation. If a patient has a dyskinesia and they have a tremor and they shake, that'll be a hard patient to work with. The TMJs, does the patient have some trismus or cannot open appropriately? And the neuromuscular system, are they having muscle pain? Their posture and position, are they supine or are they sitting up? Their relationship of the maxilla to the mandible, skeletally. The supporting tissues, did your record base impinge on the tissues? The alveolar ridge size and shape, the amount of saliva and the character of the saliva, tongue size and position. And of course, we have a huge part to play. Our skill level, the record-based comfort and stability. If it's pinching, the patient's not going to be able to get in a comfortable position. The technique you use when you're recording your CR, you're allowing the patient to swallow or you're taking your thumbs and pushing on them. The amount of pressure applied on the ridge and by the wax rim. What's the recording material? Are you just using wax? Are you using silicone? Are you using zinc oxide eugenol? What's the articulate you're going to use, and is it arbitrary or not? How do you verify your CR record? How do you interpret your record? What does that really mean? Well, in this paper, they found there's a strong correlation between the quality of the residual mandibular alveolar ridge and the accuracy of the jaw records was the key variable. So the name of the paper is Investigation of Factors Influencing Patient Satisfaction with Knee Complete Dentures using that type of modeling. These two things affect the new prosthesis quality. But your CR record is very important. And understand that patients are neuroplastic, they will adapt. So if due to attrition and wear they were a class 3, and you arrange them as a sort of pseudo class 3 or edge to edge, they may adapt. Every patient is different. And of course, as you go from removable prostheses to fixed prostheses, if you make a mistake with any of your basics, this could be the price to pay. Well, we can see the transition line for this upper provisional all-on-4 isn't adequately apical with the patient's high smile line. And then here is a fractured prosthesis, removable prosthesis. It's a painting by my daughter who, I think at the time she was about 4, and I asked her, what's this? She said, silly, that's the shadow. So what are the emotional effects of tooth loss in partially edentulous and fully edentulous patients? There are many. And the World Health Organization considers being fully edentulous as basically being handicapped. So the patient is physically impaired, they're disabled, and effectively they're handicapped. And when we have a look at a typical patient, this is Helen. Helen's socially inhibited. She has low self-esteem. She enjoys eating way less. She looks much older than she is. I think she's in her 30s in this photo. And everything is magnified with ill-fitting dentures. Helen was a heavy smoker. She had 6 implants placed in the maxilla that all failed and 5 placed in the mandible. She also had an iliac crest graft and came to see me. She said, I can't work. I can't wear my dentures. I'm stuck at home. And I said, well, let's try. And so I fabricated a new upper denture and I used the existing implants on the bottom. And the issue was the previous maxillary denture was fabricated when the teeth were extracted. And of course, the fit was poor. And here she is. You can see in terms of the bone that she has here, there's very little bone to support the implants. Here's the anterior nasal spine. When we have a look at her in profile, after she's been restored and you've got her vertical dimension, perhaps I needed to move the maxillary teeth slightly further forward to help support the upper lip, but it looks a much more natural appearance. And so when a patient is accepting or going towards being edentulous, it can be a tough process. And when we look at the stages of grief, what are those? Whether you lose a parent, a limb, there's typically 5 stages of grief. And it's denial, anger, bargaining, depression, and acceptance. And so this is the same patient, obviously a different timeline. And this is after the new prosthesis has been fabricated to give her a little bit of a similar appearance where she's not very gummy in the front, but posteriorly she's showing 3 or 4 millimeters of gingival margin, which is what's been done with the maxillary complete denture. If you compare that to the generic denture from before, you can see this just looks flat, monotonous. There's no character there. So a picture from a patient is very helpful. Even if you don't have a picture of that patient, maybe their sibling, their sister. And so complete denture fabrication itself can be challenging. Here is a patient who's a class 1 patient. Here's a class 2 patient. Here's another class 1 patient. And here's a class 3 patient. And every patient brings a different challenge. And these slides are from Finlay Sutton from the UK, but they're very comprehensive. So here is a patient with a high smile line. I would say she's in her 70s with some periodontal disease and a narrow arch. And let's look at the steps involved. This is how she was when she finished university. Here she is today, challenging patient. Not a great patient for a hybrid prosthesis, but potentially a good patient for a removable complete denture. So here she is. You can see she's a class 2 patient, narrow arch, some crowns, some partially edentulous spaces. And here is his preliminary alginate with a wash around the periphery to try and capture this. And so this can be challenging. So you may take an alginate impression in a stock tray, and then you can fabricate a custom tray to take a better impression. The better your initial impression, the better fitting your immediate denture is going to be. And here she is with a CR record. The mounting, you've seen this case before. Her horizontal overlap is 11.5 millimeters, what we call an overjet. Here he's looking at the maxillary incisal edges relative to the lower lip, and we can see there's been some super eruption. And again, trying to correlate that to the articulator, and then moving those teeth vertically so that they are not as super erupted. So reducing the vertical overlap and reducing the horizontal overlap because the patient is super erupted. So you bring in the teeth apically and you're going to bring them palatally, bodily. Prosthesis has been fabricated, and this is the surgical guide. You can actually make a suck down on this. So if you're reducing bone, you may have to initially, that you don't end up with an over bulky, and you can see this is not bulky here, buccal flange. The issue is there's been no time for that bone to resorb, and now you're putting a thick piece of acrylic there, which will often distort the lip. Here is the prostheses, extractions. He didn't flap the case. To be honest with you, if this was in my practice, this case would have been flapped, and we would have reduced some of the buccal outline. Prostheses prior to being adapted. So here is the initial prostheses. He calls that an MK1 with room for improvement. Reline impression, a couple of months later, and a hard reline. You can see where the acrylic has been added. Patient is still healing. You can see the occlusal plane is up and down. There's the initial prostheses. Then coming back and starting from scratch. So alginate, custom impression, border molding, CR record. So we're looking at the lip support, the incisal plane. We want this to be parallel to the interpupillary line. We also want the occlusal plane to be parallel with the alatragal line. And that's what you're looking at here. Occlusal vertical dimension, it's somewhat arbitrary in terms of lip posture and patient swallowing reflexes. And again, he's comparing the buccal corridor, which is very important compared to how she was before. A typical mistake we'll make is we're going to set the teeth too buccal, and the patient looks like they just have an endless row of teeth. So here is the initial immediate denture, and here is his wax rim for the second or final prosthesis. Again, looking at the lip posture, now we're a little bit obtuse. Here, this is not as obtuse. You can see that the wax has been pushed forward to give the nasolabial angle some support. There's the arrangement. You've seen these slides already. Try-in of the second prosthesis, you can see he's given her the semblance of some recession and some super eruption of the maxillary centrals. Prosthesis as it's been processed. Cobalt chrome in the palate, and you can see he's got some crowding, which is important when you have a narrow tapered arch. And there's the delivery of the prosthesis. It's very nicely done. You can see there's the recession, which is what she has with her natural teeth. And here she is. Midline does not match the mandibular midline, but that's okay as long as you're bisecting the bridge of the nose. A very nice result. So, a highly aesthetic result and a patient who's very happy. Again, the 5 stages. This can't be happening. It is. I'm angry. Who cares? I'll bargain with you. You have no power to negotiate. I'm depressed. Get over it. Oh, well, accept my fate. What are you, crazy? Some patients will go through those 5 stages and get to acceptance. Some won't. And so when we think of these patients as they go through their journey, this is Narissa. Narissa's from Taiwan. And the oral health related quality of life. What is this? Quality of life when it comes to oral health is the functional deficit, pain or discomfort, which may be acute or chronic, the social aspects of the disease or the illness, which affects their communication and social interactions, and psychologically the appearance of self-esteem. Narissa came to see me partially edentulous in the maxilla, partially edentulous in the mandible, with spaces where the papilla had resorbed in the maxilla and complaining of gas because when she was breathing and talking, the air was coming in, and a failing mandibular dentition and inability to tolerate a mandibular removable prosthesis. We took out the mandibular teeth, placed implants on the bottom, made her a maxillary complete denture. She said, the lower is great. I want implants on the top. So it's a subjective evaluation of oral health, functional and emotional well-being, a sense of self and their expectations, and a satisfaction. And for some patients, it's related to diet. For some, it's related to appearance. Typically, for all of us, it's a mixture of one and the other, form and function. When we have a look at something called the Oral Health Impact Profile, it's a 14-item questionnaire that looks at functional limitations, physical pain, psychological discomfort, physical disability, social disability, and handicap by the patient. So they can fill this form out prior to treatment, and then they can fill it out after treatment, and you can compare, and it gives you a more objective measure of the impact of what you did on their oral health. So it's a way of measuring. And again, you see a patient here who had a failing maxillary dentition. We've made a fixed prosthesis in the maxilla and nothing in the mandible, and you can see the appearance and the aesthetics. She actually looks pretty happy here. It's just the shade and the form and so on. In reality, patients will go to great lengths to masquerade or hide what's happening. So when you look at this patient, she looks quite different here to there and here to there, and I'll show you what's happening. So she's partially dentate with super eruption. This is wax that she's put in her mouth so that when she smiles, people don't see this. And look at the ridge relationship. Maxillary posteriors have super erupted to hit the mandibular ridge. She has alveolar eruption here and there, and a complicated case. In this instance, we did an ostectomy in the maxilla, ostectomy in the mandible, upper complete denture, lower fixed prostheses. And again, her appearance is quite different before and after. If you don't reduce bone, and you don't communicate with your surgeon about what is expected, then you have a problem. So, should edentulous patients be constrained to removable complete dentures? The use of dental implants to improve the quality of life for edentulous patients. This is Ed McGlumpy. He used to be professor at Ohio State. He's now working with ClearChoice, which is the company that I work for. And the conclusion of the paper is this. Implant-supported dentures, including either complete overdentures or hybrid prostheses, significantly improve the quality of life of edentulous patients compared with conventional removable complete dentures. Therefore, the contemporary dental practitioner should consider other options as well as conventional removable complete dentures to restore edentulous patients. No longer are patients willing to accept a removable complete denture as the best treatment because they know, especially in the developed world, even in the developing world, that there are other options out there. But in reality, it becomes complicated. So this is a patient who came to my clinic who was treated by a prosthodontist in the city. You can see aesthetically, it's not a great arrangement. She has implants that were placed 20 years ago in the mandible, and this is tissue that was grafted from her leg, and they did a vestibuloplasty years ago. These are what we call ERA attachments. She's edentulous in the maxilla, and you can see tall abutments. This is the abutment. Here is the implant. Ill-fitting prostheses. Vertical dimension of the abutment really impacted the whole case because of the height of the abutment. So I thought, in my infinite wisdom, oh, this is a patient who will tolerate a fixed prosthesis in the mandible well. She didn't. So I removed these, and I put shorter abutments on, and I took an impression, and I made her a provisional all-acrylic fixed hybrid prosthesis. She couldn't tolerate it. She said, I can't clean, feels bulky. I want to take it out at night. I just can't manage it. And so we then went back to the drawing board. We still used multi-unit abutments and made her a titanium frame with locator attachments and a removable overdenture. So here is the framework attached to the 4 implants and 3 locators that allows her to remove this and clean underneath, and obviously a maxillary complete denture. So here she is as a young woman. This is how she presented when she came to see me, and I've closed the vertical dimension down significantly, and here she is at the end of treatment. So you can see there's less maxillary incisal display, and the whole vertical dimension is more appropriate. And from a lateral standpoint or a profile standpoint, we've gone from a class 2 relationship to a class 1 relationship. But again, I made the presumption that she'd be able to tolerate something, and she didn't. This was also a case that I did with my associate here, Dr. Amit Bunch. And so patients have something called neuroplasticity or brain plasticity, and it's our ability to wire and rewire or learn new things during life. And typically an older patient may not be as adept at doing this. So in her 70s, with her personality, which was exacting, I think she would have adapted better if I'd have treated her 20 years ago. So neuroplasticity is an important thing to consider. And again, we have a tough time gauging who's gonna have high neuroplasticity and who won't. Now let's look at this paper that was published in 2016, Edentulous patients treated with implant-supported prostheses. And so they had 52 patients with what we call the Brannemark protocol. We're going to talk about that shortly, and 23 using overdenture. They had a quality of life questionnaire, and the Brannemark protocol is basically a fixed hybrid. Results for treatment expectation, understanding the type of treatment, phonetic function, speech, chewing, pain, and self-esteem were analyzed. Both treatments presented satisfaction above 87, with no statistical significant difference between them. 82% of the patients treated with the overdenture prostheses and almost 81% treated with the Brenner mark had no complaint with pain. So that's 4 out of 5, more or less. Psychological factor is a complex variable in patient satisfaction that influences quality of life. Considering the desires of patients in choosing the type of prosthesis is critical to treatment success. Why am I showing you that slide? If I'd have listened to my patient more and presumed less, then I would have known that with Barbara. And so when we have a look at the patient here, overdenture patient, 52% of the patients chose an overdenture due to cost. With the fixed prostheses, 21% were due to dissatisfaction with the previous prostheses, and another almost 4% did not adapt to use of removal prostheses. So almost 1 in 4 patients with the fixed protocol is choosing it because they were dissatisfied with a removable previous prostheses. Let's look at another patient who had a removable prosthesis that adapted well. So here she is, Edentulous. Obviously, you can see the typical collapse of the circumoral musculature. And here she is a little over supported in the mandible. Again, profile without the prostheses, with the prostheses. And she has a lower overdenture that it has a cast frame that is poorly made. In the maxilla, typical patient not removing the upper prosthesis at night, and they end up with mucositis and inflammation and so on. And the issue with this is that often the acrylic will become a reservoir for bacteria and fungi, and there is an association between nocturnal wear of dentures and aspiration pneumonia, and they're more likely to have apnea if they're wearing the upper denture at night. Here is the prosthesis that's poorly made. It's fractured here. And then when I remove the prostheses, you can see it's a high water design. There's no issue there. So I remove the prostheses. We've got multiple fractured prosthetic screws and wear of the abutments. You can see there's damage to the abutment. So I've removed the abutments. Also, the implant position is a little more lingual than you'd like. So I've removed the abutments, placed shorter abutments, obviously new prosthetic screws, and you can see here is a fractured prosthetic screw. There is a fractured prosthetic screw. This is the abutment screw. I've been able to remove the fractured prosthetic screw that was in here. And here is calculus buildup that shows you that you got a poor fit between the prostheses or the bar and the abutment. And so I've gone ahead and I've put temporary copings on. I've made her a provisional fixed prosthesis, which she adapted to quite well. I won't tell you that I locked out the acrylic during that because, you know, that's a rookie mistake, but I did actually. So that was not a good day. And then we've gone from that to this with a CAD-CAM fixed titanium frame. If I had to redo this, I would make my titanium a little thicker. She has an upper denture, and in probably 8 years, she's had a maxillary complete denture reline and fractured an upper tooth. So pretty successful. So prosthetic success is optimum AP spread of the implants, passive framework design, and minimum cantilevers. This is her old denture, not the new one. And this is her husband, who I did a full mouth rehab on, 28 crowns. Maxillary versus mandibular resorption patterns. Let's talk a little bit about that. In the maxilla, we get a centripetal resorption. It's inwards. Centripetal forces, if you're going a roundabout, you feel a force pushing you in. So that the maxilla is resorbing back and in. In the mandible, we're resorbing down and out, what we call centrifugal. So you get a reverse horizontal relationship of the two jaws, with the mandible being wider versus the maxilla. So here is a patient who was recently dentate. And then with time, you will end up with significant resorption. And typically the bone loss in the mandible is 4x compared to the maxilla. And you get an anterior posterior mandibular rotation. So you get chin protrusion and displacement and a pronounced lip. And this was my dental assistant's late mother-in-law, who ended up getting a significant basal cell carcinoma. that perforated her cheek. We treated her with a mandibular overdenture and a maxillary complete denture. So Talgren's research, where she looked at patients over a 25-year period, proved that we have a lot more resorption in the mandible than the maxilla, and that we know that the rate and pattern of resorption changes or varies. So you may end up with a horizontal discrepancy posteriorly and a significant vertical discrepancy. The maxilla is becoming narrower buccolingually and shorter anterior posteriorly. The mandible becomes wider buccolingually and longer anterior posteriorly. And remember, atrophy doesn't discriminate. This is a 38-year-old patient. And look at the amount of posterior atrophy he has. He had his mandibular posterior teeth taken out at the age of 20. He was in federal prison for a long time. And so you look at the pano and you expect this to be a 70 or 80-year-old. It's not. And so let's look at a patient who's edentulous in the maxilla for a long time. This is Sydney. You can see the typical relationship of the maxilla compared to a dentate mandible. You will often end up with combination syndrome, which is a flabby or loose maxillary tissue and enlarged maxillary tuberosities. And you end up with a significant amount of structure that needs to be supported. In this case, sort of was a game changer for me because it allowed me to look at things through a different lens. Here he is. He had minimal bone in the maxilla. We ended up doing a bilateral sinus lift for him. We placed 6 implants. So bone graft here, bone graft there, minimal bone in the premaxilla. This is still in the sinus and that's in the sinus. And tooth number 18 is now gone. So he has a single implant in 19. And I made the mistake of closing the contact between 30 and 31. I've actually gone back and I've remade this crown and left an open contact. And so when you look at the implant positioning, it's pretty good positioning relative to the ridge. And again, these are not in the premaxilla. This is in the sinus, but the implants are angled forward. But now superimpose this upon that, and you see the result. So this is a straight abutment, that's a straight abutment, and these are angled abutments to allow me to come out in the premaxilla so I don't have a significant anterior cantilever. Here he is. That's what the tissues look like 8 years later. Not bad, especially since he hasn't been doing a great job with his hygiene. And I just saw him the other day. You have a little bit of bone loss right there, a little bit of bone loss here. Posteriorly, they look great. And this is the open contact that I'm talking to you about. So bone quantity classification. We have the intact alveolar ridge. This is Lekholm and Zob's classification. Minimal alveolar resorption. Those are good patients to treat. This is where they're starting to get resorption to the basal bone. This can be challenging because it's so skinny. In a way, this is actually a better patient because you've got a nice triangle of bone where you can place a short, wider implant compared to that. And then here, you're either talking about zygoma implants, pterygoid implants, or sinus lifts. If you can catch a patient in stage A or stage B, you're in good shape. And in terms of bone quality, again, the Lekholm and Zob classification, class 1 to 4, where we're looking at the dense cortical bone, and then we've got the inner layer of trabecular bone. Healthy bone is dynamic, and it undergoes a process of modeling and remodeling. So type 1 is basically more or less homogeneous cortical bone. It's not great. Type 2, you have a thick cortical layer surrounding a dense trabecular layer. This is good bone. Type 3, you have a thin cortical layer surrounding a thin trabecular layer. And type 4 is the worst, where it's thin cortical bone and basically fatty or marrow bone in the middle. And so these types of patients can be very challenging, especially if you're trying to immediately load. What about soft tissues? Well, soft tissues, I think, are very important. And this is a hybrid patient that we've treated. These are Straumann implants. What's the relevance of the peri-implant mucosa and the importance of the dekeratization and the abutment emergence? Obviously, here you have some inflammation. This is a patient who's had radiation. And the number of implants can impact the patient's ability to clean. If you eliminate this implant and move this one slightly here and slightly there, you increase your inter-implant distance. So increased number of implants equals less inter-implant distance and more difficulty with hygiene and access with a water pick and/or floss. If we go back to the horizontal and vertical relationships, important you understand prior to surgery what you're trying to achieve. Many times the patients are going to look like this pre-surgery. So you have a skeletal relationship and then your proposed dental setup and the impact. So here's a class 2 relationship, and it may be due to mandibular deficiency, maxillary excess, or both. And patients who have dysgnathic occlusal relationships, dysgnathia is where, or dysplasia, or anything that's dys means it's off. So this is a complex situation because this is a class 3 patient, and it needs you to think a little bit outside the box. Again, a class 2 skeletal pattern may be due to mandibular deficiency, narrow maxillary arch form. Maxillary incisors may be protrusive, and that's what we call a class 2 div 1, or upright, class 2 div 2, and the mandibular incisors may be procline. So this is an interesting slide because this is a patient who did one arch first, was restored as such, and she came back for me to do the other arch, and I ended up redoing top and bottom so I could get the teeth in a better relationship because initially I set her up as a class 2. But now that these teeth are coming out, I can bring them back in. Neuroplasticity is the ability of the patient to adapt or undergo maladaptive changes. So here is a class 2 div 2 patient, 100% vertical overlap. And again, this patient, if you open up their vertical dimension significantly and they don't adapt or they have maladaptation, they may end up with temporomandibular dysfunction. So we have an ability to adapt, but not everybody does. Class 3 malocclusion may be due to a prognathic mandible, a retrusive maxilla, or both. And sometimes it's severe, like this, where you can see this significant discrepancy. Sometimes it's unilateral. And so how do you compensate? What's the impact of the skeletal relationship versus what your proposed dental treatment is going to be? So here is a patient where we did an upper and lower hybrid for. And you can see I've attempted to get him into a class 1 here. This is edge to edge. And we've tried to bring the mandibular incisors back, but I don't want to bring the maxillary incisors too far forward due to lip biting. And the issue is my emergence profile. This is a straighter button. If I change that to a 17, that brings it more on the lingual. You can see one is on the lingual, one is on the facial, but that's not really too difficult because I can close that up with pin composite. Maxilla, no problem. In reality, it's more complicated because here's another patient who you can see he's got a complicated occlusal plane, got some attrition and wear of these lower incisors, class 3 relationship in the lower right. And is it really a class 3 or did the mandible resorb out? When you have a look at him, he's partially edentulous. He's got some perio on number 19. This tooth needs to go. But we're saving everything else in the mandible. So we placed an implant in 29, Pontic 30, implant 31. Took this out. He didn't want to have an implant there. We did crown and bridge on the lower anteriors. So here you see the molar is gone. Natural tooth, all ceramic crown, 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 natural tooth, and then an upper hybrid. So you've got to look at your treatment from a restorative-driven perspective. What do I mean by that? You've got to understand where you're headed before the implants that are placed, because it's subjective decision-making. Here's a class 2 patient. Where are your lower incisal edges going to be? Here's a class 3 patient. And after the fact, it's kind of difficult to talk to the patient about crossbites and so on. And so what you're really trying to do before treatment is figure out where the teeth are going to be relative to the bone and how much soft tissue and hard tissue you're trying to compensate for. Aesthetically, phonetically, what are the oral hygiene implications of that prosthetic material, whatever that may be. And you're trying to fabricate a surgical guide so that the surgeon understands what you're trying to do. It's a 3D communication tool. And prior to surgery, there's different approaches. So here is another patient with significant maxillary atrophy, no bone in the premaxilla, and we're doing a bilateral sinus lift, and we're going to be placing 3 implants and 3 implants. You can see again, there is no bone here. The only thing you can do is a floor of the nose lift. So advanced alveolar atrophy needs either bone grafting or what we call extra-alveolar implants such as zygomas, which I don't do. Is a more contemporary approach warranted when you have limited alveolar bone? Sometimes. So here is a patient with a lot of health issues where we're trying to place implants in the available alveolar stock. So you can see here she has a septum in the sinus. So we're placing an implant there, 4 in the premaxilla and 1 there. Or are we going to try and treat the patient with just bilateral sinus lifts? Again, you can go ahead and fabricate a sophisticated guide, which is basically a denture with some radiopaque markers. Here are the radiopaque markers to allow you to see where you're going to be placing your implants precisely and fabricate a stereolithographic printed guide. So here is planning where the implants are. And this is a guide that's going to be supported on the buccal by pins that are placed. So this is tissue borne, and you're drilling blindly through these to place your implants, and you're relying upon the guide being 100% precise. We don't do this because there's a certain element of what I call blind faith. There is the implant positioning. And of course, post-operatively, the surgery impacts the prosthetic treatment. So here's an implant in the lateral position, and there's a locator attachment, and there's very limited room. And so oftentimes, components and prosthetics fail due to inadequate space. And so the post-surgical prosthetic space is the difference between long-term success versus repeated complications. So here is an overdenture, 2 implants on each side, cobalt chrome, versus PFM in the mandible, and a nicely arranged case. When I was at the University of Michigan, I did many of these versus a fixed treatment. And the more sophisticated your treatment, the more precise you need to be. So this is a patient that I referred to Argentina. And you can see here we've got very sophisticated treatment planning where we're placing an implant in number 5, an implant in number 6, an implant in the central, implant in the central, implant in the canine, canine, premolar, and this is done flaplessly. And here is the surgical guide. And I know that anteriorly I'm going to have to be cement retained. And so here's the prostheses, screw retained FPD on the upper right, cement retained bridge, in this instance, 3 individual implants. I did not ask for this middle implant. This was one that he sort of threw in. The plan was a 3-unit bridge. So it's really a combination of art and science of what you're trying to do. And so now let's talk about traditional hybrids. And traditional hybrid prostheses really are rigid anchorage of a removable prosthesis using splintered implants and different materials. It could be ceramic metal or resin metal. This is the first hybrid that I made when I moved here in 2002. This was on a cancer patient. We placed 4 vertical implants in the anterior mandible, and I went straight to the fixture, didn't use an abutment, and I'll talk to you about why. Here is another patient. This is somewhat traditional treatment. This is a patient who has significant atrophy in the mandible. She had a graft from her hip, and then we did a bicortical anchorage. And so the implant is actually emerging through the inferior border of the mandible by design by the surgeon. And again, you can see my cantilever is minimal because I was concerned about her. Older patient, osteoporotic. She actually had 2 grafts. The first graft from the right hip didn't take, then they redid it in the left hip. And so the issue with traditional hybrids is the cantilever and the seesaw effect. So if you think about a seesaw, if you go to the park with your child and you sit there, your kid is going up in the air because you're typically heavier than they are. So when we have a look at it, there's a fulcrum axis. This is a class 1 cantilever, placing the anterior implant under tension and the distal implant under compression. And so you're getting compressive and tensile forces, And if you really want to get complicated and figure out how to calculate this, if A is greater than B, compression on here is this formula and tension is that formula. However, if you start to tilt this implant and you reduce your distal cantilever, biomechanically you improve A and B. So if we go back to here, A is bigger than B, here A is equal to B. Now the forces are significantly decreased on the implants. And so I would call that a more contemporary approach. So here is a patient who has 3 implants in the mandible, what we call the novum, and she's coming in with a failed maxillary dentition, and we've placed 4 implants in the maxilla, stayed in front of the sinus. I know this looks like it's in the sinus, it's not, and really improved our AP spread, minimal cantilevers. That's the benefit of tilting implants. And again, it allows you to give patients well-made prostheses. This is a patient that I saw years ago. She came to see me and I said, you either need a crown on every tooth with endo on most of these teeth. So you're talking about root canal, 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 no root canal, post and core 1, 2, 3, 4, 5, 6, 7, 8, 3-unit bridge. She said, no, I'd rather wait. And then I ended up doing this for her. Here she is in the mandible, before and after, and you can see, place 5 implants in the maxilla, 4 in the mandible, and she's about 10 years out, complication-free. So patients expect physical and mental well-being with outward physical and emotional happiness. The indications for fixed detachable prosthesis, this is a slide that I made up. Patient demand or rejection of removable treatment. Psychologically, what are they willing to take and reject? Their anatomy. They have poor denture-bearing mucosa, bony foundation, hypersensitive gag reflex, high attachments, paresthesia, or retruded tongue. Acquired anatomy may be from trauma or cancer. So the tongue form and function, did they have a hemiglossectomy? Did they have a large flap in the mouth due to resection of a ameloblastoma? And what's the nature of the mucosa and how much numbness do they have in their mouth? Do they have a dry mouth due to drugs or radiation? What's the opposing arch? Let's look at a typical cancer patient. So here is a patient that was diagnosed with a tonsillar tumor in 2010. Teeth were extracted. He had radiation, 63 gray, which is a high dose, but it didn't involve the anterior mandible. So in this instance, we've gone very, very cautiously. Teeth were extracted. I've done a wax up. I've fabricated some prostheses for him. I've looked at him holistically, tried to figure out what can he tolerate or not. What are the effects of xerostomia on traditional complete dentures. Here is his arrangement. I've tried that in prior to implants being placed. I've actually made the dentures and I'm having him wear them while the implants are healing. Mandibular prosthesis he couldn't tolerate, but I wanted him to get used to the maxillary prosthesis, which I was pleasantly surprised he could tolerate it and he could use it. 5 implants placed, waited for healing, uncovered those. You can see the tissues. He's got some inflammation, which is typical what you see with a patient who's had radiation. Here is my wax up. My cantilever, this is back in the day when I didn't have access to sort of screenshots. So you can see we've got more or less a 3 premolar cantilever. And if you look at your AP spread, if this is my anterior most implant, that's my distal most implant, my AP spread should be 1.5x. You can see here it's actually a little bit more than that, but taking into account that his opposing prosthesis was a denture, I thought we could get away with that. Here's the screenshot for the actual CAD-CAM frame. There is the bar that is being tried in. It's a grade 5 alloy, 90% titanium, 6% aluminum, and 4% vanadium. Here's the lingual screenshot, and you can see we've tried to give him some lingual embrasures that will give his tongue a little bit more room. And there is the prosthesis, and I believe he's 10, 12 years out, doing quite well with them. So how many implants are enough and are axial better than tilted? Uvo, that's me for today. I'm open for questions.
All right, thank you so much, Dr. El-Ebrashi. That's I said I'm going to need this lecture when I prepare for my post board exams. I think it covers so many things that you just assume. There's a lot of assumption made when you're trying to make this thing with your own knowledge and everything. But this is really, really very, very detailed. Thank you so much, guys. If you have any questions, I don't know if this was. I've not seen any question here, but I believe everyone. So what we do is that we go back and we watch these videos and make summaries of what was taught, so that way we can get the salient points out. But this is very, very detailed. And
how long was the previous presentation, Uvo?
It was just about 50 minutes.
Just 15?
50. 50.
Okay.
Yes.
So more or less we're done, right?
Yes.
Okay.
Thank you so much. I really appreciate this. Thank you so much for. When next are you presenting? We would like to follow you.
I don't have anything scheduled for a while. I basically don't have anything scheduled. I mean, I have some other stuff. It's only.
Do you have anything on biomechanics? I don't know. Nobody has talked about. Not so easy to find someone.
Yes, I have some stuff on all on 4 biomechanics or biomechanics in general.
But in general, and maybe specifically to all on 4s, because
I have some stuff.
I needed to call you. I saw someone loaded all on 6.
Yes.
I don't know what happened. A couple weeks later, he lost 2 implants. So
if you have the time, we can segue a little bit into all on 4 and biomechanics.
Okay. All right. Just let me know what's your availability. We have openings for June, July.
No, I'm talking about right now.
Okay. Of course.
Okay. So we're just gonna maybe another 30, 40 minutes.
Okay. No problem.
Okay. So the all on 4 concept, what is it? And how much dogma do we believe? So here is a patient that was treated with traditional implants, axially placed implants, and then they had an upper all on 4. And so if we look at the definition of dogma, it's a principle or belief or statement of idea or opinion, one that is formally considered to be the absolute truth. And so, like we talked about biomechanically, the all on 4 really is quite a simple concept. It's tends to be axially placed implants in the anterior mandible or anterior maxilla, and distally placed implants posteriorly, trying to shorten the cantilever. Oftentimes it's 4 implants, not always. Sometimes it's 3, sometimes it's 5, sometimes it's 6, and typically involves some bone reduction if the patient was dentate and multi-unit abutment. So use 4 implants, avoiding implants in the posterior regions, bone reduction, prosthetic gingiva, distal cantilever, and often an immediate load. And so it sort of comes from this paper that was published in 2000 by Krekmanov, Rangert, and Lindstrom and Kahn. And Rangert and Lindstrom are engineers. And they had a group of patients, 47 consecutive patients were treated with implants, 25 patients in the mandible with 36 mandibular implants, and 22 patients with 30 maxillary implants placed in tilted positions, followed for about 40 months in the mandible, 53 months in the maxilla. In the mandible, the implants close to the mental foramina were tilted posteriorly 25 to 35 degrees. In the maxilla, the posterior implants were placed close to and parallel with the sinus walls, tilted anteriorly 30 to 35 degrees. Patients gained a mean distance of 6.5 millimeters of prosthesis support in the mandible and 9.3 in the maxilla due to tilting. So here is the planning of the maxilla. So if you look at this patient, this is the patient, this is Narissa, this is the lady who was partially dentate from Taiwan, and this is planning the mandibular implant straight up and down because she had lots of bone and implant placement. A few years later, she comes back. And what I'm doing here is I'm measuring from the occlusal portion of the composite, from here to there, about 15 millimeters. And then I can measure again how much bone do I have left. Then the maxillary implants have been placed. Now she has acrylic titanium versus acrylic titanium. And of course, as you can imagine, she's beaten up those teeth. So we've actually changed out the teeth and redone that as zirconia. But it comes from this. You get better support and longer implants in more dense bone in the anterior wall of the mental loop, giving you primary stability. And it's somewhat dependent on arch shape. So here is an oval-shaped mandibular body. You can see this is a different shape with the mental foramina here compared to that, because in this instance, trying to place 4 implants anterior to the foramen is going to be a problem. You may have to go distal to the foramen, in this instance, if you have the bone. So the arch configuration affects implant position and cantilever extension. So this is a very different thing to this. This is a good arrangement for a fixed prosthesis because you're going to have a limited cantilever. Here we got away with it. This is Mark, the cancer patient, because his opposing arch is edentulous. But if this patient is dentate in the maxilla, this doesn't work. And you look at the AP spread, you can see everything's from canine to canine, or mesial first premolar to first premolar. Here, we're basically canines or laterals. It should really be the lateral and the distal of the bicuspid. And so it all comes down to this. With a vertical implant, your cantilever is long. With a tilted implant, you're able to emerge the head of the implant more distally. The apex is more or less in the same position. So you're getting improved prosthetic support. You're also able to place a longer implant and less cantilever. So regardless of the number of implants, in theory, cantilevers should be less than 10 millimeters if possible. Here is a case we just did a couple of weeks ago. So this is on the day of conversion before the acrylic has been added in. So we've placed the implants, we've made an abutment level impression, and I've picked these 2 up in the mouth, allowing my prosthesis to go back on the cast. And look at the positioning posterior. This is excellent. Maybe these guys are too far lingual, or my setup is too facial. Here is the opposing arch. Lingual cusp of first molar, and the palatal or the cingulum of 7 and 10. This is thanks to Dr. Burstein, who's my partner, who's really taught me a lot about these types of cases. And when they looked at the success rates in the mandible, impressive. Failures were 0 at 5 years. Tilted, not tilted. Maxilla, the success rate was less. Or survival rate, sorry. Tilted, non-tilted, tilted were 95.7. So this was the first paper that showed this could be successful. And so in the maxilla, the thinking is this. You got improved prosthetic support, the longer implants. What would you rather have in your mouth? An implant that looked like this or an implant that looked like that? It's obvious. And biomechanically in the maxilla, they know that there's a 3D pyramid of bone existing anterior to the sinus wall, allowing a longer tilted implant that follows the inclination of the cortex of the anterior sinus medial to the buccal plate. Also, the apex of this is the lateral piriform rim, or more or less the canine eminence. So you have excellent bone here. So the apex of it is roughly where the canine used to be, but the head of it is emerging second by if you don't have an overly large sinus. So here is the implant or the drill getting ready, and there is the implant being placed. Doesn't always work. So here is a patient who had an upper all on 4, and this implant failed. We removed it, grafted it, left him as an all on 3, came back and did 2 more, and then did an all on 5. So it's not 100% foolproof. So the maxillary prostheses are designed to resist compressive forces. There's a higher risk of failure in the maxilla due to trabecular bone having poor resistance to bending and torsion with a cantilever. So what's the complication rate of tilted versus maxillary? Sorry, tilted versus straight. We know that prostheses with cantilevers less than 15 millimeters have a higher survival rate compared to prostheses with cantilever more than 15. So this is a patient not treated here. This patient has terminal esophageal cancer now. This has been removed. There's no evidence that complications occur more frequently with tilted versus axial. And this is a paper by Dr. Wong, who is a periodontist at the University of Michigan. Meta-analysis. What they found was the hypothesis that marginal bone loss around tilted implants is more than straight implants is not supported by meta-analyses. Typically, the length of the implants that was used is long with tilted, and most studies used implants that were 10 millimeters in length. Some studies had 20 millimeter implants. Longer implants allow more effective stress distribution for cancellous bone. And there's a splinting effect and a reduction in cantilever length. Look at this patient. Look how little this cantilever is. It's nothing. If you don't have the bone, then you do have to do something like a bilateral sinus lift. You've seen this patient before. Again, there's a minimal cantilever. If you go back here, it's amolar, amolar. But that's not an all-on-4. That's a bilateral traditional sinus lift. How robust is the evidence with the implant number? This is a paper that was published in 2018 by Tara Agaloo and Tom Taylor. The number of implants placed for complete arch fixed prostheses. They started off with a lot of potential, ended up with 93 studies. They found the use of fewer than 5 implants per arch when compared to 5 or more implants to support a fixed prosthesis to support the completely edentulous maxillary mandible, similar survival rates. So implant number doesn't mean a lot, as we've demonstrated over and over and over. But this is important. No clever arrangement of bad eggs ever made a good omelet. So successful treatment relies on a well-designed prosthesis with a good path of insertion. You do need to use multi-unit abutments to compensate for a non-axial or divergent implant. So here is a 30-degree posterior abutment relative to the implant axis. Here is a 17-degree anterior one, and there is a 0-degree or a straight. You don't want to end up with this on the day of conversion. Because how do you get a passive prosthesis or a prosthesis that will fit? You won't. So something has to change. This 30-degree may have to be a 45-degree, or if it's 17, it needs to become 30. And these guys, if they're straights, they need to become 17. Implant depth is important too. Look at this. So not only is it too deep, but it's the wrong angulation. We had to remove that implant because it was a 17-degree, sorry, it was a Brannemark MK3, and they only make a 17-degree. Implant was removed and a new implant was placed. This was done by a periodontist who was inexperienced. Big difference. And like we talked about, with a class 3 patient, you may need to change things. If this was my first class 3 case, look at where they are relative to the incisal edges and how weak everything is going to be. Primary stability is important for immediate load. Depends on the anatomy, the bone density, the surgical technique, and the macroscopic and microscopic morphology of the implant. You need to have disease under control, A1C, good bone quality, high stability, rigid splinting, good occlusion, and a passive prosthesis. It may depend on the actual implant itself and the threads and the density. So here is an MK3. This is a noble active. And you may be able to condense the bone in softer bone depending on something called a Versa kit, which allows you to do something called osseodensification. I don't know a lot about that. But you do need to extend the implants into sound native bone. So you're typically going beyond the apex. There's no consensus on the minimum insertion torque. Factors that affect stability are method of osteotomy, bone quality, implant geometry, surface morphology, and the percentage of bone implant contact. So what happens when you have a perio patient? She looks like this. Are you going to be able to get some torque here or not? Mandible, yes. Maxilla, no. These were submerged. Then we loaded. I'm going to skip this paper. This was published by Steve Ecker and some of the people that I work with in Clear Choice, where they looked at torque and how it correlated to success or failure. There's the reference if you'd like to look it up, though. Effectively, insertion torque didn't really impact too much survival rate. So when you had more than 35 Newton centimeters, survival rate was 98.2. 15 but less than 35 is 98.4, and less than 15 went down by 2 points. So does it matter how quick you get to the end? No, it doesn't. Sometimes you can't immediately load. And I think it's important that we don't rush everybody into immediate load. There are certain patients where I think it's a poor idea. And if you have a perio patient with poor torque values, I do think it's important that you consider traditional denture. Let's talk a little bit about biomechanics. The space for the framework, you need 15 millimeters from the implant head. 4 millimeters typically for the abutment to come through the tissue. 5 millimeters or more for the framework, and more or less 6 millimeters for the teeth. Obviously, a maxillary center incisor is longer than 6, but I'm talking about vertical space. AP spread we talked about before. The better your AP spread, the less stress there is on the system. If you can have your cantilever the equivalent of your AP spread, 1-to-1 ratio, you're in good shape. And abutment position and lingual bulk. Here's a 17-degree abutment for a lower incisor. And look where we are on the lingual aspect of the prosthesis. Bone reduction is critical. So these are surgical slides. Extraction. Reduction of the bone, about to reduce the tori. Here they're using a reciprocating saw. Smoothing. Then coming to place your distal implants anterior to the foramen. Drilling sequence. Implant placed. 30-degree abutment connected. And using this type of guide, you can see where you're emerging. This is pretty close to ideal. This is Dr. Ole Jensen, who's no longer seeing patients, but he's also a former University of Michigan graduate. And this is the guy that really sort of put Clear Choice on the map surgically, because he was the first surgeon they used in Denver. Here, you can see you have a divergent single implant relative to the other three, but it is a 30-degree implant. So what options do you have? You don't. You didn't. Now you have a 45-degree abutment, or you rotate the implant prior to putting the abutment on. No one should die with their teeth in a glass of water, Professor Brandmark. So let's look at a typical case. This was my very first ever case in 2012. Treated in private practice, partially dentate patient, 3 teeth in the mandible. Like a lot of you, I'd never seen a CT scan before, so I was concerned that this patient was not going to be a candidate. There's the planning. Not a lot of bone reduction, typical for a surgeon on his first case. And this is a periodontist. So of course, with periodontist, bone is sacrosanct. Thou shalt not remove bone. Here are my temporary copings. And this is the straight. I was able to recognize that that's too divergent. I changed that to a 17. Now you can see how much more parallel. Here is the post-op panel. The reason I know there's not a lot of reduction, because look how tall the copings are, and look how long the implants are. Provisional prostheses. Planning the case after the implants have been restored with the provisional. Here is the picture that comes back to me from Nobel for the actual titanium frame. So I've done a wax try-in, I've sent it to them, they've scanned it, and then these are the images they're sending me of the cross-section of the bar in the cantilever, and here are where the implants line up relative to the occlusal table, and then this is the diatoric support vertically, lingually, and horizontally. Trying in the titanium frame in the mouth, I no longer do this purely as a framework. I do it with the teeth back on. Processing the frame. There's my AP spread. Here's my cantilever. It's less than a 1-to-1. Ten years post-op. She actually came back and decided to do something in the maxilla. Extremely atrophic ridge. I watched this surgery too. Brandt Mark MK3 implants. He decided to place a vertical implant here. And the problem with straight abutments is that you have to torque to 35 newtons. If your implant didn't go in at 35 Newton centimeter torque, how are you going to torque the implant down? That implant failed. When it was 3 months after surgery, when we came to turn it, she's like, oh, I felt that. And the whole thing was mobile. We removed the implant, placed a tilted implant. Here is planning the case. And look at the difference between where the new coping is emerging relative to the old coping. So if nothing else biomechanically, it shows you how close you can get. A little bit of bone loss here. And that was due to a loose abutment screw and a fistula. Again, 1, 2, 3, 4. But typically patients will come in and they've already had implants placed for an overdenture. So some of these patients start off edentulous. They have an upper denture, and you start to ask them questions. And so you're listening to their symptoms, which is a subjective manifestation related by them to you in the history, and you're looking for signs. So you're really trying to correlate, is what you're seeing makes sense, that the signs and the symptoms add up. You can see she's atrophic, especially in the maxilla, little prognathic, and 2 implants that have been placed for a ball abutment overdenture in the mandible. So I think we can make a new upper denture. Obviously, this is monoplane occlusion. The issue is the cantilever and the lever arm that you have with an overdenture. Narrow ridge, poor candidate for a removable treatment, especially when you have a fulcrum. In this instance, we've decided to leave those 2 implants alone, remove the abutments and use them. Lots of prosthetic space, you're not doing any reduction. And now you're starting to look at where is my foramen, and can we tilt it to implant without running into the apex of these. And what happens if you have an anterior branch coming from the foramen and there's damage to that? And again, I'm not a surgeon, so I'm not going to talk about that. But here it is. Here she is with a bulky acrylic titanium prostheses. She's probably 9 years out, and she's now a 5-year plus breast cancer survivor who's had IV bisphosphonates. So she's not a good candidate for implants in the future. The key is to match the retentive characteristics of the prostheses to the mental and physical condition of the patient. Well, what about a partially dentate patient? Because most of our patients that are coming, we're going to see different types of patients. Terminal dentition, failing teeth, versus edentulous. So here is a patient from Afghanistan. Maxillary teeth are in pretty good shape. He's had a partial denture made that you can see that they started to actually cut into the tooth. And he's got a failing mandibular dentition. Diastema here, little space there. The maxillary teeth are in good shape. So what do? We extracted this tooth and did 2 implants for a fixed partial denture. And we placed 2 implants behind this, took out everything on the bottom, restored the vertical dimension of occlusion, tried to open up the VDO so he's not so class 2 div 2. Here are the maxillary teeth. Here is the mandibular teeth with the pano. Planning the case 2-dimensionally. So we decided to do an FPD on the upper right. Upper left, just 2 implants, extracted number 15. Try-in on the bottom. Acrylic titanium. Today I would treat this patient with zirconia on the bottom. Here is the implant bridge on the upper right. He's done some bleaching. There's no veneers or anything here. And then we have 2 crowns on the upper left. I've also plastied this tooth. This has not been crowned. So left alone, left alone, left alone, left alone, left alone, left alone. Plastied the incisal edge. Nice aesthetic result. Like he said to me, patience is bitter, but its fruit is sweet. What about digital setups and arrangements? So here's a typical partially dentate patient, heavy smoker, failing dentition in the mandible, also failing dentition in the maxilla, but for now we're focusing on the mandible. Mucogingival defects, perio, lots of native bone. Planning and bone reduction. You can see when you measure from the incisal edge of 23 to the apex of it is 20 millimeters. So by the time you take out the tooth, there's not a whole lot of reduction to do. You're just reducing. You're just smoothing off. Make sure that the prosthesis is made with adequate clearance. In this case, this is a digital case where we have a digital RX for arranging the teeth. Plane of occlusion, arrangement, curve of SPE, vertical and horizontal overlap. What are we changing to, if anything? Surgical guide, milled PMMA prostheses, and a printed interocclusal record. Teeth are extracted, implants are placed. We're now taking a abutment level impression. These are neodent implants. So this is the multi-unit abutment. It's the impression coping. Here is the prostheses after I've picked up the anterior 2 with just acrylic. Here it is on the cast after everything's been reduced. Soft tissue model. This is what it looks like straight after surgery. You can see the suture lines. And now we're reducing and making this more favorable. Adding composite on the facial and the provisional prosthesis. And there's the radiograph of it in situ. And here's a publication from Dan Galindo and Cesar Butera. They published this in 2011. At this point, they're looking at 3-year study of 857 implants in 219 patients. These are 2 friends of mine that practice in Phoenix. They've probably done more all-on-4s than anybody in the US. I don't know how many thousand cases they've done. I think their clinic opened in 2007, 2008. Ours opened in 2009. Same surgeon, same prosthodontist from beginning to end. Be nice to see a publication on this with a 13-year follow-up. And look at what they found with axial implants compared to tilted implants, survival rate. very high. And they had a diverse group of patients, partially edentulous and fully edentulous patients. They had smokers, they had diabetics, and they had severe bruxism. They did include people with neoplasia, poorly controlled diabetes, and bisphosphonate use. It takes 20 years to build a reputation and 5 minutes to ruin it. If you think about that, you'll do things differently. Let's talk a little bit about upper hybrids. Again, support moves posteriorly, implant length increases, and you get decreased posterior cantilevers. We talked about the anatomy before, the 3D piece of bone anterior to the sinus. You've seen these slides already. Uvo, any questions at this point? Uvo? Okay. Let's talk a little bit about biomechanics and some of the research. So there's something called the M4 placement, where this resembles the shape of an M, where you have implants tilted at 30 degrees. The implants engages the M point, or the point of maximum bone mass at the lateral piriform rim above the nasal fossa. The AP spread is more than 20 millimeters, and typically the implants are emerging in the second premolar position. In this instance, you can see the cantilever on one side is significantly shorter than the other because this patient is missing a second molar. Over on the other side, I have made the cantilever a little bit longer because the patient wouldn't agree to have this extracted. When we look at one of the papers that was published 12 years ago or 11 years ago by Bevilacqua from Italy, this was a finite element analysis paper. And what they did is they compared this model with 4 vertical implants in the premaxilla and a 13 millimeter cantilever, compared to a model where you have 2 vertical implants and 2 tilted implants. And they had different scenarios. All vertical 13 millimeter cantilever, slight tilt, 15 degrees, 9 millimeter cantilever, 30 degree, 5 millimeter cantilever, and 45 degree, which is not really that feasible, and 0 degrees. So ignore this last category somewhat. So your cantilever is going down as your tilt goes up. Interestingly, the implant length also went from 15 to 18, which is another variable. I didn't like that. I would have preferred they were all 13. And when they looked at the stresses in the bone, on the distal implant, the anterior implant, and the metal frame, and the cancellous bone, this is how it is all vertical. Here we are with a 15 degree tilt. It went down by 13%, 18%, 11%. And then when you went to a 30 degree tilt, it went down even more. Significantly. 50% on the distal implant, close to, 52%, 31% on the metal, 54%, 54%, and 30%. So finite element analysis is a versatile way to analyze using simulation models. However, it may not necessarily be clinically applicable. Limitations are, it may differ because they may be using homogeneous peri-implant bone and implants. Mechanical data varies among patients, may not be available. And the assumption that 100% of stress is transmitted along the interfaces may be unrealistic. And the results aren't clinically verified, but they give you trends. Hard to do this research in a patient from an ethical standpoint if you don't have some kind of in vitro data to help you support why you're doing it. So before we conclude, let's look at a patient and talk about treatment planning. This is Donna. Donna's very, very bright. She has non-syndromic hypodontia, where she's congenitally missing many teeth. So she was missing 4 and 5, the lateral over here. And in this instance, she's had an implant placed to replace the bicuspids, an old bridge, canine to central, and then a failed bridge here. In the mandible, she had a bridge on the lower left, molar, pontic, molar, anterior bridge, posterior bridge with 2 canines that are virgin. So this is how she presents. So what do you do for this patient? She has mucogingival defects and recession. This is number 2. Number 3, implant, canine, abutment, 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 abutment. So you could do lots of things. You could do an implant bridge here. You could do an upper partial. You could recrown everything. Many different treatment options. It all depends on the patient and her age. In the mandible, we elected to extract this tooth due to the post and core and place 2 implants. 1 in the molar and 1 in the bicuspid. In the maxilla, she had the option of implants in a central and a canine position, or an upper all on 4. We did that for her, restored it. Here is the provisional. You can see her smile line's a little bit high on the left side before I made the final bridge. Unfortunately, she disappeared and came back, and this implant had failed. This prosthetic screw had gotten loose, the abutment had gotten loose, and now we had a long cantilever. So that implant had to be removed. We've gone ahead and done indirect sinus bump, implant placement, left her as an upper all on 3, and did an upper all on 5, restored her with a zirconia upper bridge and a lower 3-unit FPD. Meet your patient's mind before you meet your patient's mouth. That's from my late father, who practiced in Talat Harb Street in Cairo, close to downtown, and he left the States in 1969 and practiced more or less until he passed in 2005. And I want to dedicate this lecture to him and everything he taught me. Thank you.
Thank you. Thank you so much, Dr. El-Ebrashi. We have time for like 2 questions here. It says, if we are placing posterior implants, can we remove spongy bone, place cortical bone grafts, and place the implant to escape the angulations and longer implants?
Great question. And I'm going to punt on that one because I'm not a surgeon. I think you've got to be careful when you're removing bone, knowing that, I mean, if you have a patient who doesn't have adequate bone, you need to find a way of getting some kind of anchorage. So, I mean, when you're removing spongy bone, what you're doing is talking about cancellous bone. That potentially, yes.
Okay. Another question here. So why do you remove bone before placing implants?
You remove the bone before you place implants because typically when you're taking out a tooth, you have an extraction socket and you may have a granuloma or infection and so on. So you're trying to place the implant beyond the socket into native bone. Also remember, you have a prosthesis with a prosthetic gingiva. So you need to create adequate space. You wouldn't really do that for an immediate implant for an upper lateral or a central because your crown is emerging from the CJ. So it's a different concept.
Okay, nice. One was wondering about the anatomy. What happens after a sinus lift? You know.
What do you mean by that?
The question here is by Noah Barsim. Says that if you're doing a sinus lift and you put the implant in the sinus, does the sinus come back to its position after years or something?
So typically when you place bone in the sinus and you do a sinus lift, that bone remodels and becomes bone. Yes. So you're not going to have further pneumatization because you have bone there. So there's a research paper that came out that talked about sinus pneumatization, and it's not necessarily the sinus per se that it's getting bigger. It's the actual sockets that are resorbing, so it looks like the sinus is encroaching. But you're basically getting atrophy of the alveolus.
Okay. All right. Last question here. It says, thank you very much for this presentation. How do you stage a full mouth case of implant-supported prosthesis with an uneven occlusal plane? I guess,
Great question. So typically what you're going to do is you're going to plan it so it becomes difficult when you're doing an upper prosthesis against natural teeth where you have an irregular occlusal plane. And that's why I showed you the case of the patient where we did a lower all-on-4 and I did an enameloplasty on the opposing. But if you're doing an upper and a lower, well, then you have all the control in the world because you can arrange your curve of Spee, curve of Monson. I mean, you have all the controls. It's basically, if you're making an upper denture against natural teeth on the bottom, you're going to need to equilibrate the lower teeth so you're getting some balance. But if you're doing an upper denture versus a lower denture, then you're in good shape.
Yes, yes. Thank you so much, Dr. El-Ebrashi. This has been, I don't know, this has been a great blessing to all of us around the world. From you know, several more people are going to watch this. You know, we have 1,000 people in the group right now, and everybody goes through this material. Thank you for contributing to our knowledge, and many blessings to you.
Thank you. I appreciate it. Good luck to you all.
All right.
Thank you.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator